All right. Hi, guys. All right. just going to get right into it. I've been trying to hit this 15-minute mark for you guys, but I promise it's a really interesting case and I'm excited to share it with you guys. I did this for our department here. We do grand rounds every month. So I'm here at UC Health in Colorado. So, all right, I'm going to get started. Captions should be showing up. So sorry if they're a little delayed. That's just the way PowerPoint captions work. All right. The title of my case was Preserving Quality of Life While Managing von Hippel-Lindau Syndrome. A little bit about the patient. He's a 29-year-old male born with this VHL. He has a pretty active lifestyle. He likes to hike and ski, and he does work from home. He, at the age of 7, had a left endolymphatic sac tumor removal, and that left his left cochlea and vestibular system completely ablated. In 2019, he started noticing a decrease in his right ear, so that's when he got another MRI, and they identified a right endolymphatic sac tumor. He was still in Texas at the time and got fit with an Oticon Open S1 to help with that hearing loss that he was starting to notice. In November 2020, he moved from Texas to Colorado and established care at UC Health here at UC Health. So that's kind of when we first started seeing him and his records started to populate in our Epic system. A little bit about von Hippel-Lindau syndrome. 1 in 36,000 people have it. It is genetic, and really the syndrome itself doesn't have any symptoms, but it's um, the growth and cysts that come from the syndrome and them impinging on various structures throughout the body. That's what elicits the syndrome. I wanted to note that everyone has a VHL gene, but it's mutations in the gene that allow those tumor and cyst cells to grow and get out of control. A majority of these tumors are benign, but they can be cancerous, very rare. So just the treatment is early diagnosis and the monitor of this growth to make sure that it's just preserving that integrity of the bodily structures. So in 2019 is when he came here to UCL Health, and Dr. Googles, our otologist, and Dr. Lily High, our neurosurgeon, jointly decided to just keep an eye on it when one of the two things happened. Either A, symptoms started, or B, the MRI showed evidence that it was growing and potentially going to start impinging on the structures and infecting the integrity of the inner ear. This was his MRI in June 2018 or June 18th, 2020. This axial view is showing the size of it. So you can see right there a 14.8 by 13.33 or 13.3 millimeter tumor. We have the coronal view up here, so up from above, and you can see the tumor right here in yellow. You can see the horizontal semicircular canal, the cochlea, and the eighth nerve. Dr. Google's our otologist whenever these MRIs with me, so I was really grateful to have that perspective because obviously I have no idea what I'm looking at. One thing I did want to note, which I thought was really interesting, was you can see this white matter on the left side, and you don't see that, that normal airspace, or even that bone. And so that white matter just shows that complete ablation of the left side, and how there's just essentially nothing there, just fat and tissue, soft tissue. So to the left here is just a picture from Google about the normal affected areas of people who have VHL. And to the right here is what our patient is currently dealing with as his current manifestations. So he has them in the brain, spine, the kidney, pancreatic cyst. Obviously, the one that we're looking at in this presentation is the endolymphatic sac tumor. And his current symptoms are hearing loss, tinnitus, dizziness, and vertigo. So now that both of those things have happened, where A, our patient started to elicit symptoms, and then B, the MRI did show evidence that it was impinging on the structures, Dr. Googles felt really strongly about it was time to take this tumor out and remove this tumor after we've been monitoring it for around 2 years. So he took this to a multidisciplinary skull-based tumor conference, and it was agreed a translabyrinthine approach was the best option to remove this tumor. I pulled this picture from Dr. Oblesky's class, so shout out to him. You guys may think it's familiar. This green line right here, which I highlighted, shows that that translabyrinthine approach is going through the vestibular system. And the reason they chose that approach is because they really wanted to preserve the integrity of in the labyrinth of the cochlea for reasons I'll get into in just a moment. In 2000, and when he was 7, he had a transcochlear approach, which is what completely ablated that left side. So they really wanted to try something different. Because he is going into the labyrinth and probably likely going to be draining that endolymphatic, that fluid, he was pretty, Dr. Googles was pretty transparent and confident that he was going to, if he was going to successfully remove this tumor, that the patient was going to lose his hearing in the right ear. Again, he has no hearing in the left ear. And so this was a really big concern because he would essentially, after 29 years of life, be going completely deaf. So the goal was to preserve hearing. And that's when Dr. Googles and got us involved, and we started talking about a cochlear implant. So Dr. Googles really wanted to do this cochlear implant surgery at the time of this endolymphatic sac so that we didn't have to wake him up, realize something we already knew about him losing his hearing, have him go through the cochlear implant candidacy process, and then put him back under. And so he really just wanted to see if we could get him to qualify for candidacy before surgery so that we could just do that endolymphatic sac tumor removal and the cochlear implant at the same time. So this is the audiologic testing. You guys can take a pause on the slide if you want to look further at it, but he does have that mild rising to normal, sloping to moderately severe sensory neural hearing loss in the left, nothing in the left ear. It's surgically closed, so we couldn't even do like TIMPs or reflexes or anything, even if we wanted to. I did just want to note one part right here. His word rec is 80% at 70 dB. It's still a fairly good score. So for those of you who are familiar with cochlear implants, I think we all should know, but anyways, that's not a typical candidacy score that we see. So again, getting him to qualify for candidacy was a hurdle we're thinking of. So going on to his vestibular testing, overall revealed bilateral hypofunction. On the next couple slides, I have the VEMS and BNGs. You can take a look at those if you want and pause the screen. But just to wrap it up, he did have some vestibular function on the right side. So he had normal gain in the right lateral semicircular canal during V-hit. He did have a responsible warm and cool air calorics in warm and cool conditions. The findings throughout our testing were mostly peripheral. Throughout our positional testing, he did have a downbeat, which is indicative of a central finding, but we couldn't really confirm. We can't confirm a central finding purely on positionals. It's just not enough. But we are pretty certain that it is peripheral. I did want to note that his dizziness handicap was a 24, which is what we consider a moderate impairment. And I just thought that was really indicative of this patient is really debilitated by this dizziness. He used to be a really active guy and hike and ski, and now he's even just so dependent on his mom and his friends to drive him. He can barely go outside and down the stairs alone. He really spends most of his time in his room right now, which has been really tough on him. So that was really hard to hear about. Here is V-hit. Right here is that right lateral semicircular canal. You still do see those saccades. You see disorganized, organized, catch-up, overt, covert saccades, all of the above. Again, we couldn't test the left ear because of a surgically closed canal, and the right ear, we did get absent vents as well, OVEMs and CVEMs. This is his BNG testing. Again, you see that downbeat, you see a right beat and a downbeat. One interesting part of this is I did see a spontaneous nystagmus in the before caloric. So we saw that account in those responses for the right cool instead of it being because it was a right beating spontaneous nystagmus. We did see that reduced response in right cool. Normally we would expect a left beat, but there was already a right beat. So it did reduce though, so we still consider that a response. All right, so moving on to CI candidacy, he came in with his open S hearing aids, and normally we do CI candidacy with whatever hearing aids they come in and just make sure they match the target. His did not match the target, so we had to we ended up fitting him with a resound Enzo BTE with a comply tip, match those targets, and that's what we did his candidacy testing and sound field with. He does have a private insurance, so the criteria that we have here at UC Health, and well, I think it's for all insurances, this is the criteria we're going by, highlighted on the left. So he had to get a 50% or less in a +5 dB SNR with AZ Bio in order to be implanted. We did end up getting that. We did have to kind of counsel him a little bit and just make sure you're really hearing these words. Don't just assume what you're hearing. And we also had to we did 3 lists instead of the normal one, and we averaged those. So we really just wanted to, insurances are very black and white when it comes to this kind of thing. So we wanted to make sure that we were getting him to qualify. You can go ahead and pause the screen here if you would like to read these. If not, totally up to you. I just thought this is a really interesting part of this case. I just wanted to note and highlight that this patient is really high functioning, has really high level questions, and is a really active participant in his healthcare. And he just is really, really intelligent and smart, and he just wants to make sure that he's adequately prepared for this. This is a big impact on his life, and he's just really trying to make sure that he's mentally prepared for this. So this was a cool aspect of this case and to see. So like I mentioned, we did get him to qualify for cochlear or for candidacy. On device selection day, normally we have our patients come in and we have a whole spiel about AB, Medel, and cochlear, all of the accessories and whatnot. This patient already came in, like I said in the slide before, he's very involved in his healthcare. He already came in knowing what he wanted. He had read forums. He saw that morning Cochlear just came out with an updated processor, the Nucleus 8, and he really liked the idea of having the newest technology and processor. So it was really a no-brainer. We didn't even talk about Medel and AB, and he chose Cochlear because he liked the streaming capability with his hearing aid and liked the streaming to iPhone capability as well. So it's not FDA approved yet, but any people who have a cochlear implant get activated after August 18th, they'll be able to exchange their processor to the Nucleus 8 once that's FDA approved. So some possible complications. There's really so much we can gather from imaging, so they don't really know what is the extent of how affected the tumor will be until they get in there. So it's a possibility that the labyrinth of the cochlea is too impinged or can't house a cochlear implant. So the last resort would be an auditory brain implant. Obviously, I think we know outcomes from that aren't really super promising, and he wouldn't even be able to get that here at UC Health. He would have to go to LA or something. Another complication is he's going to very, very, very likely, because it's a translabyrinthine approach, have a absent vestibular on the right side now as well. So when that happens, it leads to oscillopsia, which is kind of like that patients feel like they're on a bobblehead, and it's just a malfunction to the VOR. They don't have anything to compensate with. And then we're just doing serial MRIs until he has a surgery to ensure that the tumor's not growing. So just hoping that tumor isn't growing. So in 1 week, we have surgery date. 1 week from today, I'm really excited. I get to be a part of it and go watch. I've been following this patient since I got here. So that'll be a cool experience. So 1 week from today, we'll take out the endolymphatic sac tumor removal and likely implant with a cochlear implant. All right, in summary, I think this is just super relevant because it's just every part of our scope of practice coming together. I was really impressed, and it was a cool perspective to see that interprofessional relations had a big influence on the final recommendation, and everybody, even the patient, was an active participant and a really great self-advocate. And it's just eye-opening to see the insurance side of cochlear implants and just how strict they are in candidacy and how it's very black and white. I wish that they could just kind of see the medical side of it a little more and understand that, but it is what it is. All right, these are my references. I hope I made the 15-minute mark. Hope you guys have a great day. Happy Friday.